What I'd like to do now is just point out something obvious. It's been a great discussion. We've reviewed a lot of information on diabetic macular edema. We've explored ways to improve the management of the disease at the provider and at the health plan levels too. And before we end this peer exchange, what I'd like to do is get some final thoughts from each of our panelists. So what we're going to do is give you each about, 30 seconds or a minute. Nobody can interrupt you. Dr. Kitchens.
Well, I'll tell you, we're in a really exciting time for what we do as retina specialists. We have treatments now that are able to restore vision in many patients. Early treatment's critical, prevent retinopathy progression and reverse retinopathy, and so it's a magical time to be a retina specialist. Probably the most moving thing that I do is when you can actually turn to that patient and say, you know what, you're going to get better. And they never hear that. And it's a message of hope that we can give our patients, that they, if they follow up and if they receive proper treatment, they're going to see an improvement in their vision, improvement in their eye, and it rejuvenates them. And I've had more than one patient who's gone from an A1C of 13 to 7, stop smoking, lose weight, because they not only understood how this was affecting their eyes and their body, but finally they felt like they were enabled to take charge of their disease.
Dr. Peskin.
Thank you, Dr. Salgo, Singh, and Kitchens. Great to be with you, and thanks for allowing a lowly general internist to be on a panel of this august stature. So we really dealt with the micro and the macro. So we lasered in on, pun intended, into this important clinical complication of diabetes. And we talked about some of the challenges and issues associated with getting the screening done and then getting the right treatment for the right patient at the right time. And certainly within this area, we recognize the importance of that. That said, there is this macro environment we're dealing with, and you brought it up well, Peter, where there are a whole variety of competing interests. I am sanguine, I am enthusiastic, because I do believe that as we work collaboratively, collegially, as you said, Peter, with our clinical partners, that we're going to see improvements in overall care, attenuating or bending the cost curve, as they say inside the Beltway, and seeing better levels of patient experience of care.
Dr. Singh, last but not least.
You know, the points that John made are really quite important, I think. The outcomes of our patients now can be assuredly good with proper intervention, proper screening, and proper care. And there's really no reason why any patient who's diabetic now should go blind, given our current therapies and given our current options. We have had a revolution in care to the point of where you consider what we have right now the statins of cardiology. And in that sense, we've really come a long way in our field, where we had nothing, and we have something that's really quite tangible and quite good for the patient and outcomes and perspective now. So
that's just, it's remarkable. You know, sitting here, one of the great joys I have is listening to these panels from time to time. This has been, again, pun intended, an eye-opener. It's amazing. I have heard for the first time in my career that we can take diabetic retinopathy and turn it around. That's nothing short of miraculous, and I am privileged to practice in this environment and privileged to be at this table with all of you. That being said, we're just about done. So on behalf of our panel and the editors at the American Journal of Managed Care, I want to thank you for joining us. We hope you join us again. I'm Dr. Peter Salgo, and I'll see you next time.